Unaendelea kutazama Citizen Town Hall kutoka Parking by Radisson Blue hapa Nairobi, ambapo tunazidi tu kujadili masuala ya afya na maswali tu yanazidi kuingia ni mengi. Hebu tuzungumzie tu swala kidogo ambalo limetajwa na wakili Madoo hapo kuhusiana na wale wanaoenda kotini kushtaki hospitali kwa kuwazuilia hospitalini. Maimuna ni mmoja wale ambao walizuiliwa mwaka wa 2010 katika hospitali ya Pumwani. Atakuwa anatueleza tulikuwaje wakatoka na walifikaje kotini. Maimuna, simama tu kidogo. Mlizuiliwa kwa muda gani na mlipoenda kotini mliambiwa vipi?
Ni hospitali tulizuiwa kwa siku 24. Tulipoenda kotini, tulifanya kesi, tukashinda kesi. Ikakuwa county watulipe, na mpaka saizi hawajatulipa. Tulikaa nao kikao mwaka wa 2017, ikakuwa watatulipa kabla election, na mpaka saizi hawajatulipa na wamenyamaza hivyo, hawataki kusema chochote. Kwa hivyo sisi tunangoja mpaka wa leo, na kila kitu yote ya kesi kotini niko nayo, petition niko nazo za kesi kotini, vile tulifanya kesi na vile kesi ilienda.
Asante. Betty pia ni wakili, ataweza kutueleza kidogo kuhusiana na hizo amri zinazotolewa na mahakama.
Thank you, Mashirima. So in this case, Maimuna's case, the court gave specific orders to the Ministry of Health and recommended or ordered that the Ministry of Health should put in place guidelines that speak to a waiver system, so that for any patient who cannot afford to pay, their bills are able to be waived. The other thing that the court said is that the Ministry of Health should also put in place every single measure that it can, legislative, administrative, policy measures, to ensure that this policy or this practice of detention is eradicated once and for all. And so my question really to the DMS is, are you aware of these court orders? And what is the ministry doing to ensure that these court orders are enforced? And in light of the UHC, how do these principles factor into your plans, if at all?
Indeed, there are so many court orders that have been issued out regarding patients who have been detained, and indeed what the ministry has done is to be able to develop guidelines of waivers, waiving patients who are not able to pay or who are able to pay part of the bills. That mechanism is in place. It is the enforcement that needs to be strengthened. So that is being undertaken. But again, also we are coming up with those policies under now the universal health coverage. Because the universal health coverage, it will entail that Kenyans, wherever they are able to access the much needed essential interventions without experiencing financial burdens. And especially the poor, the indigent populations. This is the focus. So under the universal health coverage, and you look at the 4 pilot counties, that Kenyans in the 4 pilot counties of Isiolo, Machakos, Nyeri, and Kisumu, they are actually able to access the much needed services without any financial constraints. And this will be the spirit.
Even as it stands, the government is still struggling to provide healthcare to everybody else. You say under the UHC, you'll be able to do that even to the Mwananchi and the farthest ground. But how different is it going to be? How do you intend to execute that?
Trevor, is happening. If you visit the 4 pilot counties, what is happening is that the government has been able to remove the user fee that used to be imposed on anyone accessing services from level 2 to level 5. Now the level 5 are the hospitals like now Jaramogi Oginga Hospital or maybe Kisii Referral Hospital. Those are hospitals providing specialized services. The government has been able to remove the user fee that had been, if you go there for any operation, surgery, whether it's a craniotomy, it is free in these facilities all the way. And then therefore, if you want to access services now to Kenyatta National Hospital from those 4 pilot counties, you'll then be able to access services because the government has set a fund, a special fund for those people who have been referred from those pilot counties to go and get the services from the level 6 facilities. That will be catered through the NHI.
All right. Yeah. Mishra, before I come to you, let me just listen to Angela here. Does this happen on the ground, the people you deal with? Do they feel the impact of this?
Not completely.
Yeah.
And it's interesting that we've started the discussion about universal health coverage.
Yeah.
And there's a very big misconception in this country that UHC is only equivalent to removing the financial barriers. Realize that UHC has more to that. There's the issue about equity, and equity is ensuring that there's fairness across the country. So every time I hear us talking about piloting in 4 counties, I wonder, so what happens to the rest of the counties? Where is the issue of equity, and how can we use UHC and equity in the same statement and pilot in the same statement? To me, that is the biggest thing, because we cannot be piloting what is supposed to be equitably across all the 47 counties. 2, there's the issue of quality. And I want to underscore that those 2 things, because we cannot talk about removing the financial barriers without talking about equity and quality. Yeah. And last year, in February, there's a report that was launched by the Minister of Health, that is the confidential inquiry into the causes of maternal deaths in this country. And one of the leading cause, 9 out of 10 women who died in delivery, for example, from maternal health related complications, died as a result of poor quality. So as we are talking about addressing issues around quality and UHC, where do we bring the issue of quality? Where does quality come in? Because quality is the greatest contributor of the poor maternal health outcomes that we are seeing. So I think we need to interrogate the data and what we are, the statistics that we are getting, and try to link them to what we already, the new things that we are bringing on board, and bring on the flip side, bring the element of the voice of the citizen, the user. When we go to them to ask them what is best for you, what does this mean to you, what does equity mean to you, what does UHC mean to you? So there's much more than just looking at this side as the stakeholders and forgetting that the common citizen also have a voice and a role to play in whatever else that we are planning for them, because I think it's about equal participation and ensuring that every stakeholder's voice is heard and is on the table.
Dr. Swarup, before I come to you, Jackson, I know you want the right of reply to that. Yeah.
Okay. Thank you.
Dr. Swarup, go for it.
Thank you. First of all, to achieve the universal health coverage with care, we should have a national audit system for each and every one and all hospitals and health providers to give the audit report monthly and yearly for yearbook, so that if we don't know the incidence prevalence, we will be misguided. Anybody can quote anybody, anything. We have to know what disease prevalence, what is the cause of death, what is the cause of morbidity, how many success rate, everything has to be audited, number 1. Number 2, the demand-supply ratio has to be appropriate. As for example, health personnel, we are tremendously lacking health personnel because of lack of education. Medic, paramedic, and all support staffs are not there. Number 2. Number 3, we should have quality control. Quality control, what chalk powders are coming? Health equipments, devices. We should have a proper strategy and prerequisite how to avail, how to quality control the medicines, disposables, surgicals, prosthetics, equipments, and furnitures.
So then are we just shooting from the hip here? Are we putting the cart before the horse? Because if you're saying this has not happened and yet we've already started rolling out.
I'm not saying it is not happening. It is happening. It is also not happening. We have to happen 100%.
Which one is it? Is it happening or not?
We'll come there now. Number 3, we have to vet these medical tourism things.
Yeah.
Kenya is ahead of 20 years, I tell you now, many African countries. Kenya can be income generation country for destination as medical tourism and travels. We can make it. We should not make everything in India. Why? Hysterectomy, India. Fracture, India. Replacement joint, we are doing in $3,000. India is taking $10,000. Kidney transplant, we are doing $8,500. They are taking $15,000. But we are taking India because there is cocktails in between. How to make money? We don't know who is the doctor, who is which hospital. There is students, these African students are used as commission basis agents in India. So So we have to vet these things through ministry and medical board and proper vetting system.
You sit in a health committee. What are you doing about it?
I have
Because you
already
seem to be
started this thing
complaining
as a
like all the
bill.
other Kenyans.
It was in the newspaper. I have already started. It is taking time, but it will happen. I told you Rome was not built in a day, but it was built.
Angela disagrees with this, but
No, I mean, slowly, we are taking. Now, let me tell you, one thing is test tube baby. Nobody is going outside Kenya now, test tube baby. Even people from Georgia is coming.
Okay.
People from Malawi, Burundi, South Sudan are coming.
Okay.
So the thing is that Kenya, you know what we Kenyans have? The best brains in Africa and world. So we'll achieve it. Thank you.
Angela, before I come to you, Dr. Kioko.
I don't even want to mention the issue about medical tourism, because why are Kenyans going for medical tourism? Because the cost in this country is prohibitive. It is too much. Who regulates how much is charged? Who regulates, who speaks for that person here in this country? How many people can afford that test tube baby in this country? 80% of the Kenyans cannot afford.
Madam, let me tell you. I want to tell you right now, as we are charging $3,500, the cheapest in the world. $3,000 replacement reconstruction cheapest in the world.
That's about 350,000.
Yes, but below that you cannot maintain the quality.
That, Dr. Swami.
My dear Mr.
Even though it's the cheapest in the world, not very many people can
we
do
cannot
that.
maintain the quality if you go below that. Remember, we are not a manufacturing continent. We have to depend everything
Importation.
Am I correct? So we also regulate there. So slowly. A human being from Kenya used to spend to South Africa and Mumbai $28,000, $14,000 to $28,000 with air ticket. But nowadays it has $3,500.
Okay.
Let me tell you, I can give you writing. India charging $15,000 for kidney transplant. Kenya charging $8,500. The problem with us, we don't know what we are. Thank you.
Angela, do you agree with that? And then
Yes.
Dr. Kioko also wants to jump in.
Yeah. Actually, I want to support Mheshimiwa because I think Kenyans, we don't believe with what we have. Where I sit and where I clear so many people to go abroad, I see Kenyans who are not satisfied with the care that is being provided here. We have not believed with the professionals. That's one thing. Despite the fact that some specialized care may be very expensive, but we have not believed in this. It's high time we've started now embarking on building our systems. And I believe in the next coming 5-10 years, Kenyans actually will not be going out to India or wherever. I have noted that a sudden decline in the number of Kenyans who are coming now to seek to be clear to go to either to India or wherever. We need to believe in our systems and we need to build this Kenya. As Mheshimiwa is saying, Kenya is far ahead of many African countries and we want to build the health systems in this country. It is not about the Minister of Health. It is about everybody. All of us, we need to come together and say, what is it that we want for this country? I just want to echo what, to say something about what Angela said about the universal health coverage.
Yeah.
It's not that we slept one day and woke up and said we want universal health coverage. A lot of discussion has gone into this for a whole year. And we needed to, because nobody knew about universal health coverage. You cannot just start implementing universal health coverage in the 47 countries because you want to address equity. Start small, grow, understand the lessons, and then you'll be able to move. We did a lot of assessment. We did a lot of assessment in these counties.
Yeah.
We were able to collect data. We were able to know how many human resources are needed, what are the challenges in terms of equipment, in terms of infrastructure, in terms of commodities, in terms of even the community health volunteers, and all that. And then we are able to say, now, can we be able to select counties that now give a representation of what is happening in the country?
Before you spread out to the
yes,
others.
we
Okay.
chose Machakos.
All right.
Because why? Because of the high burden of traffic accidents.
Okay.
Then Machakos will represent all those counties that experience traffic accidents.
All right.
We went to Kisumu. Why? Because Kisumu has a burden of communicable diseases. We went to Nyeri. Why? Because Nyeri has a high burden of non-communicable diseases.
Okay.
And then we went to Isiolo because we wanted to see a county that now represents the nomadic populations.
Okay.
Now, those 4 counties will be able to give us lessons
Okay.
that then we can be able to use before we scale up to the remaining 4 counties.
All right. Mashirima, bado kuna maswali pia.
Naam, Trevor, hapo kabla ya kuendelea tu kwa maswali, Daktari Kioko na Daktari Mishra wanasema kuwa lazima Wakenya wawe wanaamini mambo yao, lakini nadhani pia viongozi wanapaswa kuongoza kwa hilo, manake wengi tunaona wakitoka nje kwenda kutafuta matibabu, hawayatafuti hayo matibabu kwa hospitali za serikali. Labda unaweza kutujibu, kama viongozi hawaamini, basi wananchi wataamini vipi hospitali zao?
I want to tell you it's different nowadays. You will see that even our leaders are accessing services in hospitals.
When was the last time you went to a public hospital?
Pardon?
When was the last time you went to a public hospital?
Myself?
Yes.
I usually go to public hospitals. I go.
Which one?
When I'm in my rural home, actually the last time I was in public hospital was in December, on the 23rd.
Angela doesn't agree.
No.
Should we start by having the leaders that seek these services so that they know what's
Trevor,
really
let me
happening?
tell you one thing.
Yeah.
It's about the mindset of our people. It's about believing. And it's about believing that we're going to get there is equivalent of the same BP machine that is going to be used in that public facility. It is the same BP machine available somewhere. The same thermometer that is going to use you this, it is the same.
Angela doesn't agree.
Trevor, thank you so much. And I think there's something that we say at White Ribbon, and is that, and this is based on what we've heard from communities and citizens, that we will believe in our health systems in this country, especially the public health system, when we see our leaders leading from the front. That means that we'll be able to see a member of parliament, a senator, a governor going to be treated in that hospital that you are telling 80% of the population to be. And that is a time we'll know that quality has been exercised, or their quality equipment and everything in that health facility. Let me tell you a very interesting thing. From last year, April, we started a campaign where we're asking women, what does quality mean to you when it comes to reproductive health care? And we have been shocked, because as much as I say that Kenyans do not believe in our system, this has been informed by something. What has made Kenyans not believe in our system is because quality is of essence. And one of the greatest things that we are seeing is issues around disrespect and dignity. And that is what we are discussing today. You go to that health facility, how are you treated? Are you going to go back? When you go to that health facility, you cannot access. You cannot access that health facility after some working hours, for example, antenatal care. After 12, you are told, go back, come tomorrow. You cannot have your child immunized. Yes, everything could be there, but are the systems really responding to the needs of that citizen? And for sure, until leaders lead from the front, we cannot really say Kenyans will believe in the system. Make us believe in the system.
Okay.
Yes.
By taking the services yourselves.
Exactly.
Mashirima.
Ndilo swali hilo tutakuwa tunangoja kuona ni viongozi wangapi basi. Daktari Kioko hapo anasema yeye kila mara anaenda katika hospitali ya umma. Nadhani itabidi tumfuate tuweze kuona kama anafanya hivyo. Tunapumzika kidogo, tunarejea hivi punde.